Hello and good afternoon, everyone. We have a slightly different format today, of course. The technology being what it is, our setup in our usual location, conference room, seems to have taken a summer vacation. But we're okay and we're alive and we're doing well. So I just want to take this opportunity to welcome you all to this, our 6th session of MRF HIV/STI Echo. I am Dr. Boyce. You can't see me today. I am formless. I'm just a headless one. But we're going to have a really entertaining session today at our STI session. So we're going to ask Dr. Selena Todd to give us some information about STIs in general and men in particular. Because one of the things that we know has been happening around the world is STI rates are rising, especially among men and men who have sex with men. So we're going to have a sort of a global view of STIs in general, and we welcome Dr. Todd. Her presentation, every time she does a presentation, is always fabulous. So we thank her for taking the time and spending the effort. And I will admit in public that I owe her some sushi for this, so she will come, she'll come collecting very soon. So we shall start the presentation very briefly. Now, my setup in my office isn't quite as good, so if you're having difficulty hearing me, please make sure and let me know. All right, so I will get those slides started. Give me a second.
Okay, so good afternoon once again, everybody. What I was saying is that this topic is so pertinent. COVID-19 has really disrupted services, care and treatment, and it's a phenomenon that's being reported everywhere globally. So STI services are not being, symptoms and services not being addressed. Even the US government has expressed their concern and has actually given more money for STI treatment and care because of this hidden pandemic within the pandemic, right? So we're going to have a look at STI in general. We'll do a global perspective first, then we will narrow it down to men. So we could start. Next slide, Dr. Boyce. So these would be our objectives for today. We do a global perspective of sexually transmitted infections. We know that STIs are a global phenomenon, that you have at least a lot of them being reported every single year. We must remember the numbers 30, 8, 4, and 4. We'll then look at syphilis, trichomonasis, gonorrhea, HPV, and herpes and its manifestations. Next slide. So we always talk about 95, 95, 95 where HIV is concerned, but I want us to remember the numbers 30, 8, 4, and 4. 30 represents the amount of pathogens that are transmittable during sexual activity. Then the number 8, there are 8 in total of eight are linked to the greatest incidence of sexually transmitted diseases. 4 of them are currently curable: syphilis, gonorrhea, chlamydia, and trichomonasis. There are 4 of them that are viral infections and none that are incurable, which is hepatitis B, herpes simplex virus, HIV, and of course, human papilloma virus, which is linked to cervical, anal cancers, and warts. So the numbers 30, 8, 4, and 4. So in the bacteria, we have, for the 4 of them that are curable, we have Trichomonasis, chlamydia, and Treponema pallidum, which is syphilis. Those are 3 bacteria. The protozoa is Trichomonasis. The viruses which are not curable, but which we can manage is HIV, herpes, HPV, and hepatitis B. Next slide. So this is a global incidence, and it's such a difference from the HIV global map. In the HIV global map, the burden of disease is in sub-Saharan Africa. With STIs, the burden of disease is actually in well-developed nations more so. So before curable STIs, the burden, 75 million in North America. You have 86 million in sub-Saharan Africa, 23 million in the Middle Eastern countries, 51 million in India. But then when you think about the population sizes, 51 million versus 3 billion persons. So this is the global prevalence of the 4 curable cases of STIs. Next slide. This presentation is about men and women. So we look at the prevalence here and we realize for chlamydia, gonorrhea, and trichomonasis are largely female dominant. So the prevalence is highest among women for chlamydia, which is the present slide we are looking at. It is greatest, chlamydia is greatest in the regions of the Americas as compared to the African regions. It may be also associated with some level of lack of testing. Next slide. Gonorrhea, likewise, the prevalence for men and slightly higher for women than the regions. Dr. Boyce, next slide. So we have trichomonasis, again, largely female dominant in all the regions of the world. Highest burden of disease in the African region. Next slide. Then we get to syphilis. It's more male dominant. Higher prevalence in all regions of the world tend to be in females compared to males. This is the syphilis slide we're looking at. The prevalence tends to be higher among males in comparison to the females in all regions of the world. Next slide. Then when we look at, basically what the literature is saying is that STIs are basically being channeled and being driven by young persons between the ages of 15 to 49. It is not a phenomenon that is being seen in older persons. It's really young persons, 15 to 49. And they looked at the different income categories. And within the different income categories, if we look at low income, syphilis is the predominant STI in low income countries for men, whereas for women, it would be trichomonasis, okay? In higher income countries, what we see for men, it's chlamydia, whereas for women, it's also chlamydia. So high income countries, it's more bacterial, which would be chlamydia, whereas for lower income countries, for men, it's syphilis, and for women, it's trichomonasis, which is a protozoa. So then we're going to now look at syphilis. So syphilis globally, it's the highest occurring STI in men, and especially in men who have sex with men. And that's a phenomenon that is being seen all across the world. Even here in our clinic, there was a study that Dr. Edwards, Dr. Lyons, and Dr. Avery Hines would have done. And they showed that the prevalence of syphilis was about 12.6%, and it was more common in persons known to have HIV than persons who were being newly diagnosed with HIV. So syphilis is a bacteria. It is curable. It is treatable. It is Treponema pallidum. There's different genres of Treponema, but Treponema pallidum is the one associated with syphilis. You have the ones that cause ERs and Pinta, but those are not what we're going to look at. We're going to look at Treponema pallidum. So best thing is to have some pictures. So syphilis, the incubation period usually can be from 3 weeks to as much as 3 months. Patients usually report symptoms anywhere between two to 6 weeks. Next slide. So there's different manifestations of syphilis. There's a primary manifestation, secondary manifestation, and the tertiary manifestations. If you have a good surveillance system, you want to catch persons at the primary level, but many persons, they don't recognize the primary level because it's painless. If it was painful, many of them would seek treatment, but it's a painless lesion. It can be a single lesion. It could be multiple superficial ones. It could be within the level of the skin. It could be on the surface of the skin. It's basically a chancre that is formed. It's very superficial. Some persons think they've cut themselves shaving, and it heals unknown and unrecognized for a lot of patients. So a lot of times we do not detect patients at the primary level. What happens is many times they show up having secondary manifestations. Next slide. So this picture shows the primary chancre on the tip of the penis. The secondary manifestations, which is so common that we would see in clinics, are macular lesions, common on the palms of the hands or the soles of the feet. Like in this picture, this is on the palms of the hand. This is secondary syphilis. Next slide. But secondary syphilis doesn't have to only be on the palms of the hand and the soles of the feet. I've actually managed a few patients where you find them on the trunk of the body, on their either the anterior chest wall, their abdomen, posterior chest wall, their arms. Sometimes it could look like if they had measles. It doesn't have to be within the skin, flat into the surface of the skin. It could be raised bumps, all distributed, as I said, on the chest wall, the abdomen, the back. Fine rashes, and that's also a manifestation of secondary syphilis. So it can be macular, or it can also be papular in nature. If we fail to detect them, most patients come in with secondary syphilis. They don't ignore the rash. They seek medical treatment. But if we fail to capture patients at this stage, it evolves into tertiary. Primary and secondary syphilis would require penicillin-based antibiotics, so if there's an allergy, doxycycline, or if you have the injectables, it is usable. So it's easy to treat. Primary and secondary can be treated as outpatient, but tertiary syphilis is a different category. Let's look at some pictures of tertiary syphilis. Next slide. So tertiary syphilis, here are lesions on the arms. We call them gummas. Then next slide. Then you have syphilis also affecting the big vessel. The most common, it affects the valves of the heart. The most common one is the aortic valve, and someone can actually present with cardiac overload, shortness of breath, because the aortic valve is the valve that allows blood to be pumped down to your big toe. So syphilis can affect the valves of the heart, particularly the aortic valve, and actually create a new murmur, which is abnormal blood flow in the heart for a patient. If the syphilis is not managed at the primary stage or the secondary stage, and it's gotten so advanced that it's now affecting your heart. So this is a manifestation of a tertiary syphilis. Next slide. Then I don't know if you can appreciate these very fine little lesions, red lesions going through. This is neurosyphilis, where it's captured affecting the brain. Neurosyphilis would require 6 weeks of IV treatment, hospitalization, so a patient cannot be treated as an outpatient in this case. So you have all the complications of being in hospital, nosocomial infections, meaning being infected with hospital-acquired infections, and the presence. You can't treat the patient as an outpatient. They must be hospitalized if it's in this case. Okay, so this is an example of neurosyphilis. We know that HIV and STIs, they hold a very close relationship, and really they should be managed as one. We know that having a sexually transmitted infection creates inflammation and reduces the protective mucosal barriers that exist in the penis or in the vagina that would increase your risk of acquisition of HIV. But we also know that HIV lives in the secretions of the vagina and penis, so that if it's not managed, if your HIV is not managed, the inflammation is there and it'll increase your risk of actually contracting a sexually transmitted infection. So it's important to screen STIs because some are treatable, but syphilis in particular, because we know the sequelae primary to secondary to tertiary, it's something that should, and it's high risk among MSMs. It requires more frequent screening and tracking of clients who do contract syphilis. So here at MRF, we screen the general population once a year. Everybody gets a VDRL, but within our key population groups, VDRLs are done at least twice a year, and patients are tracked. Okay, next slide. I just wanted to show, this is not a pediatric clinic, but congenital syphilis is very prevalent. Syphilis is one of the torch infections, so women are screened. This is about a presentation for men, but men have different partners. They might have a partner who's male, they may have a partner who's female. They can transmit syphilis onto their partner. So it's important when you're treating the client that you also test and treat the partner so that reinfection does not continue to occur. So this is a child actually, an example of congenital syphilis. You can notice the buccal lesions in the mouth, the white lesions in the mouth of this child. So congenital syphilis, it can move from a male patient to a female partner, if that's the case, to a child, or if the partner is male, you can actually set up a cycle of repeat infections if both partners or partners, if there's multiple partners, aren't treated, tested and treated. Next slide. So then we come to trichomonasis, which from the prior slide, it's the most common sexual transmission among women. I'm just talking about it very briefly. It's a protozoa. It's usually a frothy lesion, a frothy discharge from the vagina. Just in case for the partners of any male patients who are complaining, this is the protozoa, this is what it looks like. So we're not going to spend too much time here because we're always talking about everything for women. So next slide. And basically the cervix has this strawberry appearance, but most times you pick this up after having a pap smear. So again, this is a presentation for men, but men who have female partners, you need to promote pap smear testing. So trichomonasis is very common to pick up through pap smear, and it can be treated with a course of metronidazole. So it's very easy to treat. Next slide. So this is the frothy discharge normally associated. It's usually a gray frothy discharge normally associated with trichomonasis. So just for knowledge. So we're moving on next to gonorrhea. So gonorrhea is a diplococci, basically 2. It's gram stain. It's a gram. You can do gram stains. You can culture gonorrhea using a chocolate agar medium, or you could use the new technology, which is a nucleic acid amplification test, which usually requires a urine sample, but you require an early morning sample. It's the best when the secretions have built up within the tract. So a urine sample is usually best for a male patient, but early morning, collecting a urine sample later on in the day may not be, unless they have that pussy discharge coming off of their penis, may not serve. You may miss the diagnosis. For a woman, not a urine sample, usually the best thing is the urethral swab, a high vaginal urethral swab, so you can get a good pasting. Next slide. So this is the discharge. It's a pussy discharge. So gonorrhea, basically it's you can't see, you can't pee, it can give you pains in your joints because you can get an arthritis. It can affect your joints. If the arthritis is so bad, you can actually get a septic arthritis. It can also give you a rash. Most times you don't get to the rash because men run to the doctor because they can't use their penises because of the pussy discharge coming out of it. Nicki Minaj talked about the balls of the cousin or whatever, but gonorrhea can actually present with a swollen testicle, not related to COVID-19 vaccine. Let me just put that there. So you can have a swollen testicle, you can have pain on urination or this pussy discharge. A lot of it is called the runs, and male patients run to the doctor all the time for treatment for this condition. Next slide. So again, this is just showing gonorrhea on the cervix. It can cause a cervicitis because, again, for male patients who have female partners, it can transmit gonorrhea. Women generally tend to be asymptomatic, do not have that pussy discharge. They may develop bleeding in between periods. They may have pain in their abdomen and their back because gonorrhea is linked to pelvic inflammatory disease, but they don't have that pussy discharge. They generally do not run to the doctor for treatment, but if untreated, it could ascend further up into the uterine cavity, causing scarring and ultimately a difficulty in achieving or maintaining a pregnancy because the pelvis becomes so inflamed and the scar tissue. So that can lead to complications for male partners who may want to have a child and then can't realize their female partners cannot accommodate because of prior scarring from gonorrhea. And gonorrhea and chlamydia are twins. So when you screen for one, you screen for the next and you treat both at the same time, even if the person is only positive for one. Next slide. So gonorrhea, just for knowledge, so we talked about the man and the pus discharge. We looked at the cervix of a woman being inflamed, but there are glands called Bartholin's glands on either side of the outer bit of the vagina that can become very swollen, and it can lead to abscess formation, and that would require, most times antibiotics will not resolve and would require some incision, meaning opening up to allow the pus to drain out. Next slide. Gonorrhea can affect your eyes. Sometimes little babies born. Of course, male partners have children. Even male adults might complain of burning in the eyes because, as I said, can't pee, can't see, but it can affect children and will require treatment. Usually child born with like what we call in Trinidad, a coal in the eye, and would require some treatment. Gonorrhea is also, they try to screen women now. I think they're trying to start screening some women as well. Next slide. So we looked at these skin lesions for syphilis, but gonorrhea in itself can cause skin lesions. It is not common for persons, especially males, to present with these skin lesions because of the pus from the penis. They tend to seek treatment so much earlier that it is rare to see a manifestation of a skin lesion from gonorrhea, but it is present. It's usually a small papule. So just a raised lesion, a papule is by definition less than 1 cm of the surface of the skin. So that's for gonorrhea, which is very common in our population. So we see syphilis and we see gonorrhea. Based on the study that was done here at MRF, gonorrhea was the second most common STI in our male patients living with HIV. Next slide. So then we've covered basically 2 bacteria. We've looked at syphilis caused by Treponema pallidum, and we've looked at gonorrhea caused by Neisseria gonorrhea. So let's change it up a little bit and we're going to look at a viral now. At MRF, we are forever promoting the HPV, human papillomavirus vaccine, which is a series of 3 shots traditionally. We know HPV is associated with warts in both men and women, cervical cancers in women, and anal cancers in men. So this is just the warts around the shaft of the penis at the head surrounding the glans penis. So we really always want to promote vaccinations as a way of combating, because even when you treat these warts, be it via podophyllin, Aldara, so Aldara either chemically through Aldara and podophyllin, or you send to QPCC and you ask for cautery, you should still encourage the vaccinations. It reduces the reoccurrence and the severity. Next slide. So this is, again, same warts from the anus, which in some cases can make it be difficult to even use one's anus. So it's really uncomfortable for patients, and it really requires identifying and treating. Yes, we had the backlash from our population. A lot of parents didn't want their children to take the HPV vaccine, but the ideal scenario is to have our children vaccinated against HPV before sexual debut. If that did not occur, to at least have persons vaccinated now, especially our male patients. For the general population, is up to age of 26, but here at MRF, we are going up to age of 45, which is the cutoff age for women. Next slide. Again, this is what's within the vagina, the vulva of the vagina. These things can grow so large that sometimes they can block the birth passage, and delivery will not be possible. And then it has to be switched to a cesarean section because they grow in pregnancy. Treatments are not safe. They don't, their safety profile has not been declared during pregnancy, safe for use during pregnancy. Next slide. Now we move to herpes. We have a few patients. So this is always the confusion. Is it syphilis? Is it herpes? They look the same. Many times patients may not feel that burning sensation. We know the herpes virus is not it's not curable. It lives within the nerves. You will get exacerbations from time to time. If a patient has had more than 6 exacerbations in 1 year, then they should be considered for suppressive therapy, which would be treatment with a cyclovir for at least 1 year. Usually they use the 400 milligram, but at least for 1 year, if you've had more than 6 episodes, you should refer the patient. And I think STI clinics should consider having offering this service where you have like a kind of service for persons who have more than 6 exacerbations, not just say, well, okay, they've had a few more exacerbations than normal. No, those patients need to be identified and put on suppressive therapy for at least a year. So the lesions, again, just like syphilis, are usually painless. The patient may complain of the burning sensation, which is the virus when it's coming down the tracts of the nerves. But once it erupts, usually they see the multiple lesions, whereas syphilis tends to be a single lesion, but syphilis can also take the appearance of multiple lesions. So this is usually the differentiating diagnosis. Is it syphilis? Is it herpes? For me, what I usually ask, because we know that herpes is not curable, it's usually the same area over and over. So you just ask the patients. If the patient gives you the history that it's coming out on that same spot, it's always the right spot, then it's likely to be herpes. Syphilis will not be so area specific, but the nerve and the eruption of herpes will always be area specific. So if it's always that same area, then it's more likely to be herpes than syphilis. Next slide. So this is just some lesions, some superficial lesions, because it's very easy for us to recognize lesions on the shaft of the penis, but this is just some superficial herpes lesions within the vulva of the vagina. Next slide. Again, with all STIs, this is just an example of herpes creating inflammation again on the cervix. Again, male patients or men have female partners, so they should be aware that if their STIs are not treated, the impact on their female partners, if the partner happens to be female, if the partner happens to be male, and your herpes lesions are not crusted over, you can transmit it on and infect your partner. There's herpes simplex 1, there's herpes simplex 2. We have this thing of saying herpes 1 could affect from your belly button come up and give you like what we would say a cold sore or cockroach bite your mouth, but we also know that herpes 1 can also give genital lesions, which is lesions from underneath the belly button come down. Next slide. Right. So we've gone through the STIs that are common in men, particularly among HIV persons living with HIV, our male populations. We've looked at syphilis, we've looked at what's anal cancers we never want to see. We want to always sensitize our male population, especially our key male population, about the need for the HPV vaccines. It's so important. Also, our key male populations, through our men's health here at MRF, to have coming into the men's health clinic, it's on a Wednesday for us to do the anal examination. Is important when we are treating with patients, to talk to them about their anus, challenges that they may be experiencing. Among men, you have, remember, we don't want a lot of inflammation happening in the anus, which will increase your risk of contracting a sexually transmitted infection. The anus has only one layering of cell, is columnar epithelium, as opposed to the vagina, which is stratified epithelium with multiple layers. Because the anus has one layer of cell, it's very easy for a male patient to contract sexually transmitted infections if they're using their anuses for sex. So it's really important, if you have a client in front of you who use the anus for sex, that you have a discussion about the health of the anus, and you encourage, if they're not comfortable dealing with a female doctor, that we have the men's health clinic. They have a male physician, very knowledgeable, that they can access, because you need to take swabs, you need to examine the anus. You need to look at things like, a lot of our patients only come to us and talk about their anuses when they're experiencing a fistula, but you need to screen to see if gonorrhea is in the anus. They may not be having the discharge, because while the symptoms of gonorrhea is usually 2 to 6 days after contact, you may have manifestation even up to as far as 30 days. So anal health is very important. So I'm just leaving that out there. Even just looking through the anus, if small warts are there, treating with those before they grow bigger and block the anus, so that it makes it difficult for the anus to be used for defecation purposes. It may sound gross, but the anal health is really, really important, that we need to have a look. If we are inspecting the anus, we'll be able to detect changes. The first time we start seeing changes, if we have a baseline, then we can look at changes, because we never want our patients to develop masses in those anuses, which will be diagnosed later as anal cancer. We want to be the gatekeepers and advocate for our patients. Last thing I want to talk about is post-exposure prophylaxis and STIs. So a lot of our patients are approaching us about, when are we giving PrEP? We know that there's a sense that if PrEP is given, it will reduce HIV transmission. And yes, the studies shows that there's a reduction in transmission of 98%. But PrEP was studied among heterosexual persons. So now they're looking at PrEP in terms of men who have sex with men in that population, to really see how effective PrEP can be. They talked about, and this is a study that came out in the Lancet in 2019. They looked at PrEP in terms of on demand. When I'm going to have sex, I use the PrEP, or if I'm taking the PrEP every single day. And they realized from this study is that the persons, and they studied these persons for 2 years. I must say, one of the limitations of the study, it was a small study, and probably this can be used as a basis for a bigger study. But they looked at the outcomes for the 2 years, and what they found is that PrEP created a false sense of security for the persons who took PrEP every single day. They actually had a higher occurrence of sexually transmitted infections than those persons who took PrEP on demand. So PrEP might be protective or risk reduction, 98% for HIV, which the study actually showed. From the study population, I think only 2 persons ended up testing positive for HIV. But the take-home message is that while you on PrEP, it increases because of that sense of security. The study showed, and this study was done among MSMs and transgender women in Amsterdam, Netherlands, and basically they showed that the increased risk of sexually transmitted infections while being on PrEP. So even though persons are clamoring for PrEP, and we may or may not get there someday, we still have to tell our patients that while it's protecting you from from HIV, which is one of the viral STIs that are not curable, but manageable, it's opening you up to a range of other sexually transmitted infections with sequelae that we would not know. For example, if you got syphilis and didn't get it treated and you reach up to tertiary and now you needed a valve replacement. So it's important patients who are either buying PrEP from the internet or getting it through some black market channel, that they protect themselves against sexually transmitted infections, which is really the take-home point from this study, right? And we really don't want our patients buying PrEP from off the internet or through black markets, because there are a lot of fake drugs that look even more original than the original branding. So really want to be guided accordingly. Condomize, condomize, condomize is the last message I would leave. Screen, make use of all available vaccines to protect all vaccines. I didn't talk about it here, but your hepatitis B vaccines for men, especially our male patients. So we have the hepatitis B vaccine, we have the HPV vaccines. Get all the vaccines that are available that could protect you against STIs, which would be hepatitis B and HPV. Condomize, and if you're not condomizing, get screened and treated as soon as you possibly can. So that's my contribution. Thanks everybody for your attention.
All right, thank you, Dr. Todd. Excellent presentation, as usual, very comprehensive. I saw a couple of messages in the chat here. All right, so I'll leave a couple of minutes open before we go to the case for anyone who has any comments or any questions. While I pull up the other slide. Remember, if you can't speak where you are, feel free to type in the chat box.
We have Cyrus putting his hand up for a comment there. Cyrus, go ahead.
Hi, this is just for clarification. In Dr. Todd's presentation, she spoke of screening for HPV. Just would like clarification if it is that screening, anal screening is being done for HPV at the men's clinic on a Wednesday.
So, okay, so there's technically, anal health is available for the men's clinic. We wouldn't so much screen for HPV. They're screening for chlamydia, for gonorrhea, because technically there have been studies that have established the strains of HPV that's associated with warts, and there's no clinical benefit of that screening. You come in the men's clinic, we'll put you and start the vaccination series, but we will screen for anal health. We want to get rid of the chlamydia and the gonorrhea that might be existing in the anus. So yes, there's an opportunity for anal screening in the men's clinic on a Wednesday, and we really ask persons to please come in. If there's a fistula there, it doesn't make sense it continue to open out even more. We can start managing or giving proper advice. Yes, we can't cure fistulas, that's something for the surgeons, but we can start being aware of it, giving out some advice, trying to get rid of infections that can make those fistulas even worse.
And just a quick word from me, one of the other things we can screen for, even though we don't have the ability to do HPV screening on the anus, we can do HPV screening from cervical swabs to type with the Abbott machine, but the swabs there aren't calibrated for anal samples. But one of the things we can screen for is anal dysplastic changes. We have caught in precancerous changes in a few of the men who came to the clinic and got them excised before they actually progressed to cancer. So I think all men or sex with men who are engaging in receptive anal sex should have regular anal screening to look for some of these dysplastic changes. I'd done a observership in Cullen Lord, and they actually do high resolution endoscopy, and they have trained endoscopists, which is a wonderful thing. It's essentially the same level of training that a sexual pathologist would undergo, but we're not quite there. It's quite a a resource-intensive exercise, but I think it is needed because anal cancer rates among men of sex with men is rising. Cyrus, you want to say something again?
Yeah, so I have another question. With regards to Trichomonas, a lot of us don't really know about Trichomonas. What are the signs and symptoms of Trichomonas?
Right, so I'm glad lots of y'all don't know about Trichomonas. It's a protozoa, but it's more common in women. It's a frothy discharge, so it's not something the literature does not have a high prevalence among men unless there's a female partner of a male patient, and usually they probably get some burning or some itching, more like a burning, but really it's usually detected through a woman and then you just treat the partner. But it's not something that's common in men at all. The prevalence is a frothy discharge, but it's more female dominated.
Okay, thanks everyone for that contribution. So I'll start the case in the meantime while I just pull it up. Again, thank you everyone for the excellent questions and Dr. Todd for the wonderful answers.